In this lecture, we're going to move from outpatient care to inpatient care. So, but you're going to see a lot of overlap between the two. As I talked about last time, talking about outpatient care, you can't really talk about one without the other. They're sort of two halves of the same coin, right? A heads and a tails. So we're going to kind of rotate around that. But I want to bring back this slide from previously to remind you about how institutions of healthcare have changed. The first hospitals, and that word hospital emerges back here during the Crusades, where European kings were sending raiders basically into the Holy Lands, so into the Middle East, to try to get so-called, and I'm using scare quotes here, get back the Holy Lands for Christianity. It probably didn't hurt that the Holy Lands were part of the Islamic Empire at that point, and that's where the money was. So raiders always go where the money is, sort of. So if you look at the history of the Crusades from the Islamic perspective, they write about it as a bunch of European barbarians invading. So it's a little bit like the way we tell stories about the Vikings invading Europe. So the Islamic Empire looked at the Crusades as just barbarians from Europe, which is probably not that far off. Anyway, excuse me. The one of the word hospital comes from an order of knights called the Hospitallers, and I can't say it in French, but it's a French word, and they set up sort of hospitals, what we would understand is really that sort of undifferentiated institutions of social welfare, but specifically for people who were participating in the Crusades and making that journey to the Holy Land. So the word hospital comes to us from the French, a French order and of knights, hospitaller. Again, can't say it right, but it really comes from way back here. But most of these institutions were tiny, like we're talking like 20 beds, and it was really just kind of a way place for people who were away from their home, right? Because we've talked about where in, until the early 1900s, did you want to get your health care? You got it at home. But if you were traveling from Europe into the Holy Lands, right, so into the Middle East, there was no home to go to. So the idea of the Hospitallers was they were creating these institutions to take care of people who were sick and injured, who were on their way to or from the Holy Lands, as in particular as part of the Crusades. So remember, way back here, the institutions that we think of as hospitals today, these are kind of the proto-institutions, meaning the institutions that preceded the creation of hospitals, really, as we think of them today. And the Hospitallers were a very small fraction, predating what we think of today as hospitals. And it wasn't really until the Industrial Revolution and the amount of and our accumulation of wealth, because these lines here represent the amount of wealth that we have. And so really it wasn't until we started to see the explosion of wealth that we saw in the 1750s with the advent of the Industrial Revolution, the beginning of the Enlightenment, the acceptance of science and the application of science to medicine, that we really start to see institutions for the indigent and sick separating out from institutions for homeless people or just poor people, right? And even then, it was still quite primitive. And so what we've seen in the last 150 years was this incredible change in what it meant to have a hospital. So let's talk about hospitals. So I'm going to highlight a few things from your book. There's a lot. This is a busy chapter. I'm going to highlight just 5 things. The first of which is advances in nursing. And one thing, if you go to work in the healthcare system, one of the things you have to understand is nurses run hospitals, right? They may not literally sit as the CEO, but they provide the workforce that actually runs the hospital. So nurses are really the backbone and nervous system of the hospital as we understand it. And the chief nurse of a hospital oversees typically half or more of the employees in the hospital. Half or more of the employees are engaged in providing nursing care of some shape or form. Not all of them are RNs, of course. A lot of them are aides, but then also many of them are higher level providers. In the United States, the federal government has had a huge impact on hospital growth. So we'll talk about that. We're going to talk about there's a whole range of different ways that we can analyze and organize the way that we think about hospitals. I want to share a little bit about New Hampshire hospitals because you are taking a course at UNH and the process of hospital consolidation. And I think New Hampshire demonstrates it very nicely as a very small state with only 26 hospitals. I think New Hampshire demonstrates this consolidation wave very nicely. And then we'll close with a brief discussion of what makes a hospital particularly unique in terms of its management structure. And as a former hospital executive myself, that's a piece of interest. So let's talk about nursing. So nurses really, like I said, are the backbone, the nervous system, the heart, if you will, of hospitals. And throughout most of history, nursing was, much like medicine, a kind of trade, often carried out by poor people who didn't have any other options. So nurses were not professionally trained. They did the work and learned on the job. And the quality of the nursing profession, it really wasn't a profession. It was just a thing that someone did. A lot of times it was, young women who didn't have other jobs and they didn't have the skills and the knowledge necessary to properly care for patients, or it was very primitive until Florence Nightingale. So Florence Nightingale really is the founder of modern nursing. So a little bit about Florence Nightingale. Florence Nightingale was born to a very British. I'm sure they were very British. They were also very wealthy, a very wealthy British family who happened to be living in Florence, Italy at the time. So she was born in 1820 to a wealthy British family who happened to be living in Florence. As she came to maturity, she chose to go into nursing over a more conventional upper class life where she would have, gotten married off to some other wealthy man from another wealthy family and so forth. And she chose to kind of lead her own life. And she chose to go into nursing, which is kind of cool. And there was very little professional training available at this point, but nonetheless, she pursued it. And in her work in London, was recognized for her talents, her managerial talents, and rose very rapidly to be the superintendent of a hospital in London, a large hospital in London. So think CEO. She was the CEO of a large hospital in London. During this time, during her life, the Crimean War happened, and this was a war between Britain and Russia for control of Crimea after the fall of the Ottoman Empire. So Crimea, hopefully you've been following the news and you're aware of this, Crimea is a part of Ukraine, and Russia has, over the centuries, conquered Ukraine, back and forth, and Crimea kind of is this land bridge between Russia and Ukraine. And right now, Russia has taken it back as of 2014, had invaded Crimea in 2014 and grabbed it back. They have since, last year, they've reinvaded or tried to invade Ukraine itself to try to take all of Ukraine as well as Crimea. So this is a thing that's a landmass that's been fought over for a long time. Anyway, so at one point, Britain thought that they should own it. And so there was a big war between Britain and Russia for control of the Crimea. And 18,000 and at the height of the war, 18,000 British soldiers were reported to be languishing in military hospitals with abominable conditions. Right, the soldiers were dying from cholera and dysentery, which are basically diseases of filth. You get cholera by consuming someone else's poo, basically. And the way that that usually happens is the poo gets into the drinking water, and then that's how you wind up getting cholera. It's not transmitted in the air. It's not an airborne illness. It's a waterborne illness. And the way you get it is somebody with cholera. And what happens when you get cholera is you vomit and have diarrhea until you dehydrate and die. And it's a deadly disease. And it's a really horrible way to go because you don't lose your mental faculties until the very, very end. So you know you're dying and you are suffering all the way up until the end. So it's a disease of filth. Dysentery, same sort of thing. Again, it's a disease that triggers diarrhea, and you basically die from both of these diseases by dehydration. So Nightingale is aware of the Crimean War, hears about the plight of British soldiers who are dying miserable deaths in British military hospitals in the Crimea, and she leaves her comfortable life again and heads to the Crimea, where she finds these terrible conditions, and she implements in particular a program of sanitation amongst other efforts. So, like I said, the diseases of cholera and dysentery, which have plagued military campaigns since the beginning of time, is a disease of filth. And so just simply implementing sanitation, it reduces the transmission of these sorts of diseases. So she goes there, and she is regarded as tireless in her role. And she was known for roaming the hospitals at night with a lamp. So this is a drawing of her walking through the hospital wards at night with the lamp. And so when she returned to England, she became known as the lady with the lamp. And you can see here down in the corner, this is a nursing pin. So when nurses graduate, they have a pinning ceremony, and almost all nursing pins have a lamp on them because the idea, the culture of nursing celebrates the idea that nurses are tireless in their care for patients. So she returns to England after the war is over, having made a major impact on the survival of British soldiers during the Crimean War, and campaigns to continue to improve military medicine and specifically nursing. And she was one of the first people to really rely on statistics. So she took extensive notes about the statistics, death rates, and numbers of patients, and all this stuff. So she had all this data, and she was one of the first people to work with statistics. So today you'd think of her as a health economist, perhaps, where she relied on this relatively new field of statistics. And of course, bear in mind, there's no calculators or never mind, no computers. So everything's done by hand here. And so she really transforms hospitals and nursing care through her reliance on science. And, we've keep talking about this idea, right? So she is a late Enlightenment figure, and the application of science leads to the professionalization of medicine and nursing. So I just want to kind of recenter us on this progression through time. So she's there in the 1850s. She returns to London, and continues to work to transform nursing care. So in 1859, she publishes a book. So at the ripe old age of 39, she publishes a book, Notes on Nursing, What It Is and What It Is Not. That's a great title, right? And this becomes a foundational text for nursing education around the world. And in 1860, she founds the first Nightingale training school at St. Thomas's Hospital. And by 1873, there are 3 Nightingale schools of nursing founded in the United States, including one at Mass General. By 1900, there were more than 400 nursing schools in the US, and notes on nursing continued to be a core text for the discipline for many, many years. So let's talk a little bit about the nursing profession. So early nursing schools were primarily an apprenticeship program similar to physician education. So a kid, I call all my students kids. So a student, a would-be nurse would come to the nursing school, and the nursing school is in the hospital. So our classes are organized in the hospital, where nurses are learning basically through an apprenticeship. So they're following around a senior nurse who's teaching them how to do the things they're doing. In the United States, nurses associations gradually organized and lobbied for occupational licensing. Eventually, the RN, or registered nurse recognition, so that you can't with the idea that you would have to get a certain amount of education, a certain amount of training, and then you would be recognized as an RN, and you'd be able to command a higher income for your work. So through the 20th century, professionally trained, here's an interesting point that we think of. Through the early 20th century, so from the 1800s into the 1900s, professionally trained nurses, they'd go through their training, and then they would leave the hospital. So they do their training in the hospital. Then they would leave the hospital and go to private duty, what we call private duty, which means they'd get hired by a wealthy family who maybe had an elderly family member who had medical and nursing needs. So maybe dementia, Alzheimer's, maybe other health issues that we didn't know how to treat. They would go into private duty. So they were treating patients in the home, right? Because again, where did we want to be treated? Through the early 20th century, everyone wanted to be at home. It wasn't until hospitals in the 20s and 30s evolved into higher quality organizations where all that fancy new technology was being created and located, so that physicians could go in and do the remarkable innovative things that were happening at that time. So it wasn't until hospitals kind of made that transition to being centers of technology that trained nurses went back to the hospitals, and private duty stopped being the preferred outcome for your training. It wasn't until the 20s and 30s that the preferred employment was actually in a hospital, even though that's probably where we think of nurses the most today. And it's true, right? So more nurses are in the inpatient side or in hospitals than in any other organization. And nursing continues to evolve, right? So we had, more and more education, more and more sophistication, and nursing becomes more and more formalized. So nursing continues today to be primarily institution-based, though there are, as we talked about in the last chapter, with the explosion of outpatient care, much like outpatient care, right? It's that there and back again story. So nurses preferred to be on private duty, meaning they're out of the hospital and working in the home. Now we're, in through the 20s and 30s up through the present, nursing really moves back into the hospital and into other kinds of large institutions. And now we're seeing roles for nurses kind of reverse and starting that flow back out. Though I will say, very much nurses are still primarily institution based, but you see them, of course, in ambulatory surgery centers. You see them in outpatient settings, outpatient clinics, as well as performing public health functions. Nursing research. So nurses regularly participate in the process of exploring, of exploratory science, looking at how to provide higher quality of care, particularly in the inpatient setting. So let's transition now to talk about the federal government's role in the growth of hospitals. So something to understand about the United States and its history is the federal government through World War I was a pretty insignificant part of everybody's daily lives. The federal government did very little, and almost everything was done by the states. So the states were much more powerful, and you probably thought of yourself more of as a citizen of New Hampshire with a secondary thought that you're a U.S. citizen, as opposed to a U.S. citizen first, and then I happen to live in New Hampshire, but I could just as easily move to Massachusetts. So the U.S. federal government was very weak, and the main reason the federal government was very weak is it had no money. So the Constitution allowed the federal government to tax, but it didn't have an income tax. And that's where the federal government today gets the vast majority of its money. So where did the US government get its money prior to World War I? Well, the answer was through tariffs, right? So whenever you bring something in, an import into the country from another country, the federal government would collect taxes on imports. So there were things like that. So it wasn't until the 16th Amendment to the Constitution, which was ratified in 1913, that allowed the federal government to create a federal income tax. And at the time it was sold as, oh, we're only going to tax the rich. So just, never trust politicians when they say something like, we're only going to tax the rich. And it was a tiny tax. It's like, we're only going to tax the rich, and it's only going to be a tiny tax. And it'll never, affect the rest of the population. And just look at your paycheck next time and remember that it's just going to be a tiny tax, and it's only going to affect the rich. Anyway, the federal government begins to grow in its ability to do stuff once it actually has money. And as it gets more and more money, the federal government becomes the central power in US politics. And so today, like, how often do you think about, how excited do you get about the election of your state legislature, right? Like, so, New Hampshire has something like 400 legislators in its state legislature. If you live in New Hampshire, can you even name one of them? For the most part, nobody pays attention to state politics anymore. It's all federal politics all the time, which is unfortunate because our country is our government is really not designed. Even though we have the federal income tax, it's really not designed to function that way. And a lot of the things that we think of as dysfunction are the result of us trying to run run our government systems as if the federal government is supposed to be the primary actor, and it's really not. But nonetheless, the federal government suddenly has enormous amounts of money available to it. And so at the end of World War II, we've spent all this money where the federal government is used to, people are used to the federal government having this new big role. The war ends, we've got all, the federal government now has all this capability, what political scientists call state capacity. So the federal government has grown in size and complexity, and it now has a lot more capability, plus a lot more money. And so one of the things that the federal government, our legislature, decides to do is pass this bill, the Hill-Burton Act, or the Hospital Survey and Construction Act of 1946. Everybody calls it the Hill-Burton Act. Everybody that knows about such a thing, such as you. So you'll refer to it as the Hill-Burton Act now. Basically, in 1946, there were still relatively few hospitals relative to the population, especially in rural areas. And in 1946, the population of the United States was still very rural. So Hill-Burton allocates federal funds to build hospitals, basically promises this is a subsidy to the states. So the states put together plans to build hospitals with a goal of having 4.5 community hospital beds per 1,000 people. So the Hill-Burton Act promises money, federal funds from the federal government to the states. So the the point here is the federal government is not the one building the hospitals. The federal government is giving money to the state governments, which then funds the construction of these new hospitals. So we hit this. So we hit this goal in 1980, and this act helps build about 40% of the new beds, meaning the new hospitals that are built. Now, if you remember from the last chapter, what happens in 1983 is we realize that spending on healthcare is out of control, and we change the compensation for hospitals, and we suddenly see a decline in compensation to hospitals, which then triggers a collapse of hospitals and a reduction in the number of hospitals. So what effectively the Hill-Burton Act does is it overbuilds hospitals. So in conjunction with, the demand for hospitals, we have 1965 Medicare and Medicaid help the elderly and indigent pay for hospital use. And so that triggers a demand for hospitals. So there's money suddenly that people could be spending on inpatient care, but no hospitals. So there's a demand. And so the federal government helps stimulate the supply of hospitals by subsidizing the building of more hospitals. So this is coupled again. So that's the Medicare, Medicaid, we know are the federal and joint federal state programs that help pay for healthcare. We also talked about the emergence of private hospital insurance, the Baylor Plan, Blue Cross, that also pay for hospitals. So insurance, right? The availability of insurance creates demand for more inpatient care, but it doesn't create the supply. And so again, Hill-Burton helps create the supply of healthcare. And so today it is normal for hospitals to get 30 to 60% of their revenue from Medicare and Medicaid, in part because of the aging of the population. Right? Our population is getting much older. Many more people now qualify for Medicare than before. As you probably know, the boomers are all reaching retirement age, and many of them, we had a kind of an explosion of retirements during COVID because people are like, it's just not worth it. I'm already 65. I may as well go ahead and retire. So we're seeing a lot of people drawing Medicare today. And that really, the fact that Medicare is a federal program, and the fact that they make up some, Medicare reimbursement makes up some 60% of revenues for hospitals. If I'm paying, if I'm the one paying the bills, I get to tell you what to do. And the federal government is not shy about using the fact that it pays the bills for most hospitals to implement and force changes in policy. So CMS sends out all kinds of directives to hospitals that if you take Medicare, you have to do these things, right? So this is from the financial statements from the parent company of St. Joseph's Hospital, which is in Nashua, and this is in this is in, I want to say this is in thousands, so it's 215 million, and I think this is actually for St. Joseph's. Sorry, I don't recall off the top of my head. So the point here is, what it's showing is what this graph is showing you is the amount of money they make. So in 2020 they had $618 million in revenues, and of that, 215 million came from Medicare and 139 came from Medicaid. So they pay, they are heavily reliant on the revenues from the federal government. And so as a result, if CMS, right, Center for Medicare and Medicaid, says, hey, if you take our money, you have to do X, Y, and Z, St. Joseph's is going to stand up, salute, and say, yes, sir, we will do that. And that's how that's how the federal government does a lot of its business. Is it doesn't tell state level operators, hey, you have to do this thing. What it says is, here's our money, and if you take our money, you have to do this thing, right? So it's always coupled, or it's not always, but it's often coupled with, here's some resources, but these resources come with strings attached. And that's not just healthcare, right? That's road building, that's schools, that's a whole slew of things. That's how the federal government is able to direct activities at the state level. Is it doesn't have the authority necessarily to just direct the behavior at the state level, but it can offer money with strings attached. So I mentioned a second ago, the PPS, the change towards PPS from fee for service to PPS comes about as a result of the Tax Equity and Fiscal Responsibility Act, known as TEFRA. And that's an important one for you to remember. I will be asking about this on the exam. So there you go. In 1982, right? So in 1982, TEFRA gets passed. It changes a whole bunch of the way that the tax system works. But one of the things that comes out of TEFRA is the implementation of inpatient PPS in 1983. And we talked about this last time, right? So we shift away from cost plus to PPS reimbursement, right? Fixed reimbursement. So it's no longer, reimbursement's no longer based on cost. The result is it encourages a shift to shorter stays. Well, shorter stays means we need fewer beds. Fewer beds means we need fewer hospitals. And those shorter days, as we talked about last time, become much more intense, right? So we also see the shift away from inpatient care and inpatient stays at all to greater use of outpatient. Now, there is a lot of outpatient work or ambulatory work done in hospitals. But again, that just reduces the number of beds, and the stays that become that remain inpatient are only the most intense, only the most dangerous procedures, right? So between 1990 and 2000, 200 rural hospitals and 300 urban hospitals closed. So just as we get to that magic number that Hill Burton was trying to get to in 1980, 2 years later, the federal government reverses course, changes the way that they reimburse hospitals, and quite effectively, causes 500 hospitals to go out of business in short order. So, this is one of the problems with having government agents make these decisions instead of letting the market make these decisions, right? As it turns out, we didn't need 500 hospitals, and that's why they folded. So some important things that you need to know about if you're thinking about hospitals and understanding what is a hospital and how big and important is a hospital. So some terms that we use to talk about hospitals. Number one is licensed beds. So this is the number of beds that the state has allowed the hospital to operate. So I want to say Catholic Medical Center has the authority to operate something like 350 licensed beds. Maybe it's more than that, right? But they actually only staff, say, like 220 beds, right? So the number of licensed beds is the maximum number of beds that a hospital can operate. The state gives the hospital permission, tells it you may operate no more than 350 beds, let's say. But at any given time, Catholic Medical Center, if I've got these numbers right, it may indeed have 350 licensed beds. It's only operating about 200 licensed beds because it doesn't need all 350 beds, because that's not the way we practice medicine anymore. So that 350 licensed beds was probably done at a time, pre-PPS, so before the TEFRA and the change in the way we do business. So they maintain the license, but they don't actually staff those beds, meaning that there are and they may not even physically have the beds anymore. But how many beds actually have nurses that would be able to take care of patients? So how many beds have nurses associated with them, such that if a doctor said, hey, we want to admit somebody, there'd be a nurse standing next to the bed when the patient comes in. And so it's usually a much smaller number. Now, so licensed beds and staff beds, there's a difference, right? Licensed beds are always greater than staff. It's greater than or equal to the number of staff beds, but typically greater than the number of staff beds. Average daily census is another way of kind of measuring how many um, patients are in the building at any given time. So you may have, 220 staffed beds, but you might have an average daily census of 150 or 180. Hopefully it's something close to the number of staff beds. And then another way of kind of looking at it is to look at the occupancy rate, which is the percent of staffed beds. So if I have 100 staffed beds and I have 75 patients in the building, I have a 75% occupancy rate, 75 divided by 100. So we definitely want to have as high an occupancy rate as possible, because otherwise we have nurses standing around next to empty beds, right? So we want that occupancy rate to be fairly close to the number of staff beds. Otherwise, we're just wasting money on manpower that's not needed. Another way that we measure hospitals and the amount of care they give is the number of discharges. So the number of patients that are discharged from a hospital. Now, why do we use discharges as opposed to admissions? Well, in particular, we use discharges because of OB patients, right? Obstetrics patients. So pregnant mom comes in, and hopefully formerly pregnant mom and baby leave. So one person gets admitted, two people get discharged. So we focus on discharges. Now, if you die, that's a discharge too. You're discharged to the morgue, essentially. So discharges is a better way of measuring the number of patients that have been cared for by the hospital than by admissions alone. And then average length of stay is the average number of nights that a patient stays in a hospital. So typically we see in small rural community hospitals, so we'll talk about what these critical access hospitals have to have a length of stay less than 3 days. But you might see average length of stay at a place like Dartmouth Hitchcock, where they're doing much higher levels of acuity. Right, Dartmouth Hitchcock is a teaching hospital, a medical center where they are taking care of very sick patients. The average length of stay there is going to be much longer than the average length of stay at a community hospital. All right, so let's talk about some different facts about hospitals. And there's like I said, there's a bunch of different ways to kind of organize and think about the kinds of hospitals. So here's one way to think about it. We can think about community hospitals. These are hospitals that are owned and operated to care for the community. So 84% of hospitals in 2019. Right? So in 2019, there were about 6,100 hospitals. About 85% of them were community hospitals, meaning they're meant to take care of the community, and they're organized to take care of the community. As opposed to psychiatric hospitals. So community hospital focused on medical issues. Psychiatric hospital, you're admitted for a psychiatric illness. So the New Hampshire State Hospital, for example, is a psychiatric hospital. So non-federal psychiatric. So it's a community-based, non-federal hospital. Then we had about 208 federal hospitals, and then another 116 of other flavors. So looking at community hospitals, hospitals again that are there to care for the community, about close to 60%, 57% in 2019 were not for profit, meaning they're literally owned by the community. So a not-for-profit entity doesn't have any owners. It is instead owned by the community that it exists to serve. So Wentworth Douglas, for example, is a not-for-profit community hospital. located in Dover, New Hampshire. So that's one town over from UNH, right? And so there are no investors that own Wentworth Douglas. Instead, Wentworth Douglas is owned in concept by the people of Dover and the surrounding area that it supports. And we'll talk about how that works. About 24% of community hospitals are owned and operated by investors. So in this case, they are actually literally, they have owners. At the end of the day, any profit that the hospital makes is turned over to the owners. And so they are for-profit entities. A not-for-profit, the difference between a for-profit and a not-for-profit is at the end of the year, if there's any money left over in the form of profits, those profits can be given to the investors who own the entity, right? So Portsmouth Regional Hospital, which is in Portsmouth, again, another town not far from, 2 towns over from Durham, where UNH is an investor-owned organization. So at the end of the year, any money that's left over, the Portsmouth Regional can do one of two things with it. It can take those profits and reinvest them into the hospital and make the hospital bigger and better and provide higher quality of care, or it can pay out a dividend, right? Meaning it pays out whatever cash the board decides to pay out, can be paid out to the owners. A not-for-profit entity, if it has any money left over at the end of the year in the form of profit, must reinvest all of the extra money, all of the profit must be reinvested back into the organization to make it bigger and better. So again, the key difference between a not-for-profit entity, and this applies to hospitals, but it also applies to any nonprofit organization, a university, for example. So, well, UNH isn't a good example because it's a state entity, but I'm trying to, Harvard University is a not-for-profit. Any money left over at the end of the year, that any profit that Harvard University makes has to be reinvested back into Harvard University to make it a better, bigger organization to pursue its mission. But a for-profit entity like Southern New Hampshire University, that's a for-profit entity. It's owned by investors. At the end of the year, if there's any profit left over, Southern New Hampshire can split that money into money that goes back into making Southern New Hampshire University a better organization, and or it can pay out money to its investors. Okay. And so then we have, 19%, about a fifth of hospitals are state and local government owned. So again, like the New Hampshire State Hospital, it's a psychiatric hospital, not a community hospital, but that's an example of a state of an organization that's owned and operated by the state. Some other ways to look at community hospitals are 2/3 in 2019, 2/3 of community hospitals were affiliated with a system. So Dartmouth Hitchcock is a system, and Cheshire Medical Center down in Keene is a part of the Dartmouth Hitchcock system. And then 33%, about a third at the time, were independent. I just mentioned Wentworth Douglas Hospital, which is a not-for-profit hospital in Dover. It became affiliated with or part of the Mass General Brigham system. I want to say actually in 2019, maybe 2020, somewhere around there. It joined the Mass General Brigham system. So it is no longer an independent entity. It is now part of a system. And that's the trend. Once upon a time, not that long ago, most hospitals were independently operated. Since the 80s, since TEFRA, it has become harder and harder for hospitals, because they get reimbursed less. It has become harder and harder for hospitals to operate on their own as independent entities. And so ever since 1983, when PPS went into place, hospitals either went bankrupt and ceased operation, or they have been gradually becoming part of larger and larger systems, trying to get economies of scale. So getting together, consolidating all the different operations. So like a lot of the back office stuff like HR, if two hospitals get together, they really don't need two separate HR offices. They can just consolidate it all into one. And so, if you've got two people doing payroll and you join up the systems, you can fire one of those people and save that salary. And so that's what is driving a lot of hospital consolidation, are the opportunities to accomplish economies of scale. 2/3 of community hospitals are urban, only 1/3 are rural. So the US population is mostly an urban population. And we take some efforts, and we'll talk about this in a minute, to make sure that hospitals continue to exist in the rural environment, even though most US citizens are urban, live in urban environments. So one way we can classify hospitals is by their ownership. We can talk about them as public hospitals, private hospital, private nonprofit, and private for-profit. So a public hospital is a government-owned entity, private hospital, and then you have private nonprofits like Wentworth Douglas and private for-profits like Portsmouth Regional. We can also think of them in terms of the kinds of service they offer. So like a general hospital, so Mass General Hospital provides general care, like all different kinds of care. But you can also have specialty hospitals. So you can, my sister once upon a time worked for a orthopedic hospital. There's the Hospital for Special Surgeries is an orthopedic hospital in New York City. So we have specialty hospitals that do just one kind of specialty. So, for example, just orthopedics or just cardiology. Psychiatric hospitals it has been common throughout time, throughout the centuries, that you have hospitals that focus on psychiatric care because it's very different than medical care. Rehabilitation hospitals. So you go from, you have a major accident, for example, you get in a car accident and you have a spinal cord injury. You'll get your initial care in a general hospital, and then once you're stabilized, you'll be sent to a rehabilitation hospital where you'll get extended care to try to help you to, maybe walk again or whatever it is to kind of bring you up to whatever new level you can be at. And then children's hospitals. So think of a lot of my students want to go work at Boston Children's Hospital. That's just one of many children's hospitals. We have Shriners also in Boston. I want to say there's another children's hospital out in the western part of Massachusetts. There aren't any children's hospitals in New Hampshire. We just don't have a large enough population to support something like that. So children's hospitals are typically in urban environments. So this is a map of all of the hospitals in the state of New Hampshire. So we have 13 PPS hospitals, which means they operate under the prospective payment system. So these are larger hospitals, and you can see they're green. They're down here, mostly in the south, where most of the population is. And then we have 13 critical access hospitals, and there's a bunch of restrictions on what they can do in order to be a critical access hospital. But one of the things about critical access hospitals is they still get to do cost plus. And so that's the difference between a PPS hospital and a critical access hospital, is the way that they get their revenue. PPS hospitals operate under that fixed payment, right? So if I get admitted to Catholic Medical Center, which is a PPS hospital, and I get a particular DRG, a diagnosis related group, Catholic Medical Center gets told, hey, you're going to get $5,000 for admitting Professor Bonica, as opposed to if I was to go to Alice Peck Day, right, which is number 14. It's over here, right next to Dartmouth Hitchcock. If I went to Alice Peck Day, they would get cost plus reimbursement. So instead of being told, hey, you're going to get $5,000 regardless of what it costs, Alice Peck Day, if I got admitted there, Alice Peck Day would calculate all the costs that all the costs that they spent on me, all the expenses they spent on me, and they would report a cost, and then they would get cost plus reimbursement for the care that they're giving. Now, what's unique about critical access hospitals is they have a couple of restrictions. They are meant to serve underserved communities. So typically, they're meant to be serving small rural communities to make sure that and they get that cost plus reimbursement in recognition that they're just not going to have the density of patients to generate revenue to stay in business. And so there's a couple of restrictions on critical access hospitals. First, they can't have more than 25 beds. So they aren't allowed to be licensed for more than 25 beds. Their average length of stay has to be no more than 3 days. So if you're up here at Upper Connecticut Valley or down here at, where's my favorite is Androscoggin. Androscoggin is in Berlin. I always get I'm friendly with the CEO up there, Mike Peterson. He's a great guy. We do a lot of stuff together through some professional organizations, and he usually takes one of my students each year as an intern. So I always have fun going up to visit the student at up in Berlin, because then I go camping even farther north up. So I go up to visit my student, and then I go up to a New Hampshire state park called Mollijewak, which is up in Errol, which is north of Berlin. And it's a beautiful river. It's a campground built around the Androscoggin River. And so I'll go visit the student, then I'll go camping. So I'd always get excited about when I get a chance to go do that. And I've already got a plan for it this year. So I'm excited, as you can tell. So again, critical access hospital, no more than 25 beds, no more than a 3-day average length of stay. And then they're supposed to be 35 miles from each other. 35 miles from another hospital. Now some of these are not more than 35 miles. So one of the reasons you could allow for having hospitals that are closer than 35 miles is geography. So we have we have the White Mountains running right through the middle of the state. And so geography can make 35 miles a very difficult 35 miles. So the governor can determine that communities, even though as the crow flies, 2 hospitals might be within 35 miles of each other, the governor can determine that, can waive that 35-mile minimum distance. So 3 reasons, again, critical access hospital, 3 requirements: 25 beds or less, average length of stay of no more than 3 days, and 35 miles from each other. And the idea here is critical access hospital isn't there to provide high levels of care. It's there to provide that secondary care that we talked about, right? It is there to handle emergency care and OB care if it can, and that's it, right? It really is just kind of emergencies and immediate low-level care. Anything that's more complicated than that, the patients are supposed to be sent on to one of the community hospitals where they can get higher levels of care. We have 5 other specialty care facilities, some rehabilitation hospitals. Hampstead Hospital is a psychiatric hospital, and it has just recently merged with the New Hampshire State Hospital, so it's now part of the same organization. And then we have the Veterans Affairs Medical Center, which actually isn't a hospital because it doesn't have any inpatient capability. So I'm not really sure why we list it as a hospital, but nonetheless, this is from the New Hampshire Hospital Association. So one of the things that was really fascinating was when I got here in 2015, almost all of these hospitals were independent. And today, almost none of them are. I think there's 3 left that are still independent, have not affiliated in some way. So looking at just the PPS hospitals, right? These are the larger hospitals. Dartmouth Hitchcock is the only teaching hospital. And you can just kind of look at, to get a sense of size, look at the revenues that they bring in. And this is in thousands. So Dartmouth Hitchcock brought in $3 billion in revenues, right? As opposed to, and then we have the smaller ones like Frisbee, which is in Rochester, New Hampshire, just up a couple towns north of UNH, brought in 355 million. So you see, and this is gross patient service revenue, not the actual amount they collect. You can see their occupancy rates. So the smaller hospitals tend to have lower occupancy rates. They tend to have lower lengths of stay. You can see Dartmouth has the longest length of stay, followed by Catholic. After Dartmouth, Catholic and Elliott are the two largest. You can see again staffed beds 260. I wasn't too far off. I was saying 220. It's actually staffed 261. Elliott staffs 255. Dartmouth, the largest hospital, staffs 422. And then Wentworth Douglas, which I talk about all the time because it's literally just one town away, has 118 staffed beds. So again, New Hampshire has 13 critical access hospitals. I've already kind of hammered this. It's actually should be 35 miles. So I need to correct that. And they get the cost plus, a mere 101%. But nonetheless, that's better than for them than not getting that. So other hospitals I mentioned, we have some psychiatric hospitals, some rehabilitation hospitals, and then we have the Manchester VA. This is kind of giving you a sense of who's connected to who. All right, so you can see Dartmouth Health includes these hospitals. HCA, which is a for-profit chain, owns Portsmouth, Parkland, which is in Derry, and Frisbee, which is in Rochester. Granite Health is headed by Catholic Medical Center, but includes Monadnock and Huggins. Solution Health, one of the more recent affiliations, includes Elliott and Southern New Hampshire. North Country Health, which is a really unique system, includes AVH, Weeks, and Upper Connecticut. And what's unique about North Country Health is all three of these hospitals are critical access hospitals. As far as I know, there is no other system that is only constituted of critical access hospitals in the United States. So this is kind of a unique animal. So the only ones that are independent as of last time I looked at this were these three: Littleton, Cottage, and Spear. And I imagine that's just a matter of time before they also join up. And again, the reason is with the change in reimbursement in the 80s, it has become progressively harder and harder for hospitals to operate on their own. They really have to join together into systems in order to achieve economies of scale, to eliminate all the, excess administrative overhead so that they can really focus on providing top quality care. All right, so now let's talk about governance, because this is something that makes a hospital different from, a manufacturing company, for example. And it's a historical reality, but it is something that's kind of unique and kind of interesting. So all nonprofits are corporations. Okay, so all nonprofits are corporations. They just happen to be nonprofit corporations. All for-profit corporations are also corporations. You can have businesses that are not corporations. So a physician that hangs out a shingle and says, "Hey, I'm in business as Dr. Smith," is a sole proprietor. There are some other forms of businesses as well. It's a little more complicated. So, but all corporations have to have a board of directors or a board of trustees. Typically, we call the board of a not-for-profit a board of trustees because they've been entrusted with the care of the non-for-profit board of directors. Two different words means the same thing. It's a board that provides oversight of the organization. And the number one thing that the board does for any corporation is it hires the hospital management. So the board of trustees of, for example, Wentworth Douglas, and let me just kind of do this as prior to, because it gets a little messier once we start thinking of Wentworth Douglas as a part of MGB, but let's say the pre-2019 Wentworth Douglas. The board of trustees for Wentworth Douglas, again, before they joined MGB, so when they were independent entity, the board of trustees for Wentworth Douglas represent the owners of the hospital. And you say, well, Professor Bonica, you just said that there are no owners of Wentworth Douglas. Well, there are in a sense. Wentworth Douglas, when it was an independent entity, was owned in a sense by the broad community, right? Owned by the people who live in Dover, live in and around Dover, and use Wentworth Douglas for their care. So the Board of Trustees has a fiduciary duty. They have a duty to make sure that Wentworth Douglas operates in the best interest of the community that it exists to serve. And this is true of all nonprofits, and then it is true. The difference between, so if you're thinking of the American Cancer Society, if you're thinking of, a soup kitchen, a church, anything like that, there's going to be a board of trustees if the organization is a not-for-profit. And that board of trustees is responsible for making sure that the organization runs and operates to support the community that the organization exists to serve. So if it's a church, right, it'd be the board of trustees of the church are supposed to make sure that the church is operated to provide services to the congregation. And so the board of trustees represents the people that the organization is supposed to be serving. And the number one most important thing that the board of trustees does is hires professional management, and it hires the CEO, right? And then the CEO hires everybody else that runs the hospital. So the CEO, the chief executive officer, oversees the execution of the hospital's strategy. He hires and fires all of the other employees. The board of trustees should not be involved in hiring and firing anyone other than the CEO. Then the CEO hires everyone else. The CEO manages the day-to-day operations, they manage the finance, and they manage strategy in conjunction with the board. So the board is supposed to oversee the overall strategy, but the CEO is supposed to develop that for the board. And in a hospital, this includes hiring all the nursing staff, most of the technicians, and all of the non-clinical employees. So it's the CEO supervises the chief nursing officer, and through the chief nursing officer supervises all of the nurses in the facility. They hire and fire the technicians that work in the laboratory and the X-ray, or imaging center, and so on and so on. Plus all the dietary techs, all of the housekeepers, whatever else you can think of, right? Now, if this was a church, for example, the minister, assuming that person operates as the CEO, would hire everybody, like everybody would work for the minister. What's unique, and I really want you to pay attention to this, what's unique about a hospital is that there's this other tranche, right? This other group of people that function inside the hospital and are not employed, hired, and fired by the CEO. And this other group of people is the medical staff, right? So the doctors and other licensed providers that are operating in the hospital, so not nurses, but doctors, psychologists, and so on, not employed by the hospital, right? They are given privileges to work in the hospital. So remember, the hospital is a doctor's workshop. The hospital exists to provide services to the community by creating an environment where physicians and other providers want to come and do the thing they do, right? Take care of their patients. So the board of trustees has to grant privileges to the providers. So a doctor can't just show up at a hospital and say, "Hi, I'm a doctor. I want to take care of patients here." No, the board of trustees grants privileges to a doctor. So if a doctor shows up at Wentworth Douglas and says, "Hi, I'm an orthopedic surgeon. I'm really good at what I do. I want to do surgery here at Wentworth Douglas," the board of trustees has to approve that new orthopedic surgeon. They probably say yes, because orthopedic surgeons bring in lots of money for the hospital. But nonetheless, a doctor can't just show up at a hospital and start practicing at the hospital. They have to be approved by the board of trustees, and the process of approval comes through the medical executive committee, or the MEC, right? So this is a committee of physicians made up from the medical staff. So when you get privileges, you join the medical staff, which are the individual licensed providers that are privileged to practice in the hospital. So the MEC is drawn from the medical staff, and the medical staff reviews the credentials of all the providers that want to work at Wentworth, at a hospital, whatever it is, whether it's Wentworth Douglas or someplace else. And then the MEC is responsible for setting medical policies around how care will be provided. And so this is what's really unique. This is unique to a hospital. And I want you to remember this for the test. This is what is unique about a hospital: is you have these two separate command structures, if you will, in the hospital. And they obviously interact all the time. But the board of trustees oversees both of them, right? The board of trustees appoints the CEO. The CEO hires everybody except for the medical staff. And when we say medical staff, we're talking about physicians and other licensed providers. The CEO hires all the nurses and all those other kinds of people, right? And the medical staff runs the privileging process. So that's what's unique about a hospital, is it's got this kind of two chains of command, right? All right. So last slide. Hospitals have to be licensed, certified, and accredited. So healthcare is, as I've said before, governed at the state level. Hospitals, nursing homes, insurance companies, all this stuff is licensed by the state and regulated at the state level. Now, the Department of Health and Human Services, DHHS, at the federal level, like the U.S. Department of Health and Human Services, there's also a New Hampshire State Department of Health and Human Services, same Mass Department of Health and Human Services, or something like it, right? But the U.S. Department of Health and Human Services certifies hospitals for participation in Medicare and Medicaid. So this is, again, how, even though the U.S. federal government can't regulate hospitals directly, what it can do is say, we can't tell you what to do, but if you want Medicare money, you have to meet our conditions of participation. And since some 60% of a hospital's revenue is going to come from Medicare and Medicaid, when CMS, which is the division of HHS that governs the Medicare and Medicaid, says, "All right, hospital, do X, Y, and Z, or we won't send you any Medicare money," the hospitals all say, "Yes, sir," and drive on, right? They do what CMS says. So you have to meet conditions of participation in order to get federal money. And in order to do that, you have to be accredited by an organization. And there are a couple of different ways to do it. There are a couple of different organizations that can do this for you. One of them, the most common one, is the Joint Commission on Accreditation of Healthcare Organizations, or known in the industry now as Joint Commission. When I was first in the industry, we called it JCO, but they rebranded and wanted everybody to call them the Joint Commission because that's so much nicer. Trust me, it's never a good day when Joint Commission inspectors show up, whether you call them Joint Commission inspectors or JCO inspectors. Nobody's happy when the Joint Commission shows up, because nobody wants to be inspected, right? Because if the Joint Commission shows up and starts walking around and decides that you have not met the conditions of participation, they will not deem you, right? So this process called deeming, right? So they have the authority to tell HHS that a hospital has either met the conditions of participation or failed to meet the conditions of participation. And if the Joint Commission comes into your facility and says that you have not met the conditions of participation, you stop getting Medicare money. So it's a big deal. There are a couple of other organizations that'll do this, but Joint Commission is the biggest one. And if you work in healthcare, you will come to you will become intimately familiar with the requirements of the Joint Commission. All right, so that's it for our discussion of inpatient care. Next time we'll talk about managed care.